I'm an associate professor in the Department of Health Policy. I form part of a group that over the course of the last 2 years has been meeting every month or so with sometimes inside speakers, sometimes outside speakers, and with the idea that we really wanted to collaborate more across departments and across schools to advance health workforce policy research. And we were fortunate enough about 2 months ago to receive a grant from HRSA, in particular from the Center for Health Workforce Data, to create the center that we had fantasized about. And although not all the faculty involved in the larger initiative are actually going to be involved in the research in the first year, we're hoping that over the course of the 4 years of the grant, we'll be able to get a lot of people involved. And even more importantly, that we'll leverage that grant to be able to do a lot more and to get additional funding from other sources. One of the ideas that one of our faculty members, Merle Cunningham, had about ways that we could leverage this grant was to start a speaker series that was a little more formal than what we've done in the last couple of years. And Merle has been kind enough to put this together and has, I think, a series of 6 speakers talking about changes happening, in particular with primary care workforce. So I'm going to let Merle introduce our first speaker, who is known to most of you, and I will sit down.
Hi, everyone. Before I introduce that, I just want to say a word about the speaker series. I'm one of the faculty members that recently joined after having spent 40 years out in the field actually running things for primary care in hospitals. I was with the public hospital system in New York for a decade, and for 20 years running a big system in Brooklyn. So my perspective is from the field. And the transformation that's happening in transforming healthcare is the theme that we've selected for this coming year, and Ed is the ideal kickoff person for that. But transforming healthcare is not just about primary care, it's about everyone that works at every level of care, because primary care, although it's the front end, is not everything. It's an important part of it, but it obviously directly relates to oral health services, behavioral health services, emergency services, hospital services, healthcare, home care, everything, not just primary care. But so the speaker series that we've set up is actually bringing in people from different perspectives. We have coming in from the Association of the State Territorial Health Authorities, the people running the support work for the Institute of Medicine Collaborative on integrating primary care, public health, population health. We have people coming in that are national experts on community health workers and what's evolving with the role of community health workers. Folks from the nursing professions dealing with patient navigation in the cancer world. Folks with the behavioral health experience that are working on the integration of behavioral health. And we have the good fortune of having another speaker from the newly funded interprofessional training program at the University of Wisconsin. So the idea every month is to have some perspective to help us all become more familiar with everything that's going on in the full dimension of healthcare, from the medical and other health professions as well, and the non-professions such as community health worker, which is a critical part of this along with care coordination. But it isn't in the same category as the professional part of it, but it's a critical part of our transformation. So moving on, I'm delighted to introduce Ed Salsberg. Ed and I have been childhood friends for at least several decades, going back to the last century. I first met Ed when he was in the health department, and I was a Fed with what's currently called the Bureau of Primary Health Care. Ed spent many years in Albany with the State Health Department and created one of the first workforce study groups in the country in Albany. Spent many years there at the university working with the health department. And then had a distinguished part of his career with AAMC here in Washington, and helping AAMC develop its workforce studies, and was the ideal person to be tapped to become the director of the newly funded, as part of ACA, Health Workforce Group within the Bureau of Health Professions. So we're very fortunate to have Ed with us, in addition to his leadership in HRSA and in this field. He's, of course, bringing in his decades and decades of experience of working on this set of topics. So, Ed?
It is exciting to be here and to help lead off this speaker series, and particularly exciting since we have funded GW is one of our 4 health workforce research centers, and so really look forward to working with GW in the coming years. I'm going to try and review briefly, where we are in terms of health workforce development and really the important role that health workforce development has in the transformation that's going on, and as well as the implications of the transformation of healthcare for the health workforce. I'll just say it's a really exciting time to be working in this area. I've worked on health workforce data and health workforce issues for several decades now, and there's never been such a high level of interest as there is now. The ACA has really helped spur a tremendous amount of interest. I mean, and it makes sense. I mean, we've now moved to give 20 to 30 million additional Americans that insurance card that allows them and will facilitate access to health care. Then the question becomes, will we have enough health professionals, health workers to help meet the needs for these newly covered individuals? So I'm going to review really where we are today and talk some initially about the general process of health workforce planning. So there are a series of challenges that we face in health workforce planning. And the first 4 are in terms of the delivery system challenges. There have been a lot of discussion about shortages. We hear primarily about primary care, but also chronic care and long-term care, behavioral health and oral health are all areas where we hear a lot of reports about concerns about shortages. Maldistribution, we hear about concerns with maldistribution. I want to be clear that in many ways, I think the maldistribution problem is greater than the overall supply problem. If you think about it, even when we put out national numbers, the national numbers of the total supply and the projected or current total demand really masks an incredible variation in the distribution. And so if I did an analysis and said, the nation needs 1 million physicians, but that assumes those 1 million physicians are going to be spread out equally and appropriately across the nation. And that's just not the reality. And the thought that you can look at a national number of supply and demand and put them side by side, and that's going to tell you whether there's access, is really false, because that assumes there's 100% migration and flow, so that it assumes that if we have more than enough professionals in New York and too few in Mississippi, that somehow they were going to get there. So we're trying to figure out, how do we better count and assess for the geographic variation and the problems in migration? So again, there are shortages. It doesn't mean that we don't have enough total supply. It means we have problems, and it may be problems of total supply, but it may also be equally a problem of distribution. Diversity. We clearly don't have an adequately diverse health workforce that represents the diversity of the population. It's obviously been a challenge for many years. I think it is becoming more important than ever as our population becomes more and more diverse. And then one that we haven't heard as much in the literature, but I think we're hearing more and more recently, is using health workers to the maximum of their skills and competencies. So even if we had the right number of workers and the right distribution, the question, are we using them effectively? Do we have practices and statutes that may in fact limit using the workers that we have? And do our reimbursement policies encourage or discourage the effective use of workers? Now, the last 2 are challenges for workforce planners. And the fact is, one of the big challenges we face is we don't know what the impact of the changing healthcare system is likely to be on the demand and use of health workers. And I'll come back to that through the presentation. And then the other big challenge we have is we just don't have all the data we want. The nation collects an incredible amount of data about our economy to inform our economy, but we really don't collect very much data about the health workforce, and this is an issue I will definitely come back to. So I want to note that there really are a very diverse number of stakeholders in the area of the health workforce. We clearly do not have a centralized system of health workforce planning. In fact, I often hesitate to use the term health workforce planning because I don't want people to think we at the federal government are doing planning around the health workforce. there are thousands of individual decision makers that will influence the supply and distribution and use of health workers. Now, I do think it's important to think about what are the components of an effective planning system, or a system that can effectively assure an adequate supply and distribution. So there's a set of technical skills, and that's the data, the models, the research, and the dissemination. And I will tell you, and I'll come to this in a few moments, the National Center for Health Workforce Analysis at HRSA is primarily geared with the technical capacity to produce data, produce studies, to inform others. In the long run, to have an effective system, you need to put in place the information and data that we develop. That requires leadership and assigned responsibility at the federal level, and then federal-state collaboration and public-private collaboration, and I'll come back to that in a few moments. And then we need levers. If I tell you that we need, if we do a study and I say we need more primary care practitioners, what are the levers the federal government has to actually do something about it? I want to talk a little bit about the role of states, because I think states are really critical here, and it's really important because we do a lot at the national level, and obviously I think the National Center has a major contribution to make, but the reality is that every state has a set of programs and policies and responsibilities that directly influence the adequacy of the workforce. So we know there's state-supported education. One of the things that a data brief that we've been working on documents that about 2/3 of the health professions education in America are supported at the state and local level. The private for-profit is really very small, and the federal role is really hard to identify beyond the uniformed services education, health professions education. So states, are major supporters financially. They provide scholarships. They regulate health professions. They license health professions. They regulate the delivery. They provide health insurance for their employees. They provide, obviously, they have a set of policies around Medicaid. So states are really the decision makers. Now, you could view this as a problem in that, we have to deal 50 times over if we want to change some of our policies. And so if you say, well, we should use our Medicaid GME different, it may mean the dollars under Medicaid that support GME, or we should use nurse practitioners differently. You have to go to 50 state legislators to get them to change policy. That can be a difficult task. On the other hand, it actually offers a wonderful opportunity for innovation and creativity. And one of the problems we've had is we haven't had the resources to do the research that's needed. So I will tell you one interesting one is New Mexico about 5 years ago or 7 years ago gave psychologists prescriptive privileges. I don't know if that's a good idea or a bad idea. This would be a wonderful opportunity to evaluate it. To be honest, what happens is, particularly around scope of practice, one state makes a change and then the profession goes and tries to lobby every other state and say, look, no one died, or we haven't found anyone who died because they expanded scope of practice. You should expand our scope of practice. The unfortunate part, it often ends up feeling like it's the influence of lobbyists that determine the changes in the scope of practice. This is an area where more research is really needed so that we better understand, should home health aides be allowed to administer medications? What are the pros and cons? Should nurse practitioners be allowed to practice independently? A whole range of questions that really requires more intense research. The federal government does have an important role. I view it heavily around the data and information. And that's not only the National Center, but in reality, there are a whole range of sources of data, and I'll come back to that. We have major investments through Title VII and Title VIII around medical education and nursing education in particular. But again, that's for identifying changes and working at the margins, and we're not the major funder. We have policies related to visas, which have an important impact on the facilitating or blocking the flow of foreign educated health professionals. We do actually support a number of state organizations, primary care associations, state offices of rural health, area health education centers that are involved with health services, but they're not directly doing health workforce planning. And then clearly our funding under Medicare, and this is particularly for graduate medical education, and Dr. Mullen has joined us, and he is an expert on this, where we spend close to someplace between $9 and $10 billion a year for graduate medical education. But as many of you may know, it's really a very a limited tool in the sense that it is not tied to specific policies or directions. And then I'll just note that the National Health Service Corps, which now has something near 10,000 people supporting 10,000 health professionals in the field, really critical to the efforts around redistribution. And then I'll talk more about our efforts to redesign delivery. Now, the National Center for Health Workforce Analysis was authorized by the Affordable Care Act. It wasn't that HRSA wasn't, or HHS wasn't doing workforce planning in the past, but this was a new charter basically for us to do more and more aggressively develop the data and the workforce projections for the nation. And the thought here, and it's really important to be clear, is the National Center for Health Workforce Analysis is really driven by data, and it's about data and information. So we do not control the number of residency slots or the number of nursing programs. We don't fund clerkships. We don't fund any direct education and training. The concept here is that if we provide good information, that the marketplace of states and the private sector will respond. And I really do believe that. I believe that there's hundreds of deans and chancellors and boards of trustees. If the federal government says we've done a study and we think we need more, you name PAs or physical therapists, that those chairmen and deans are going to say, here's a report from the federal government. So I think data and information can be extremely powerful. But I want to be clear that I also recognize there are real limits to that. You know, we've been saying for decades we need more practitioners in rural communities, so just saying it doesn't make it happen. So we think that the work of the National Center, which will help identify our needs to be matched by a series of programs like the National Health Service Corps or like funding that might be more tied to our needs in order to more effectively assure an adequate workforce. 5 core areas of activity. I'm not going to go into too much detail, but clearly expanding the data and improving the data we have, improving the projections, disseminating our findings to all those key stakeholders, the collaboration with states because they play such a significant role. And then we do have, and it's interesting being here at the Center for Global Health Offices, we do have a role in global health because health workforce migration is part of the inflow. And some of you may know that the U.S. was among 190 or so countries that in 2010 signed the Global Code of Practice on, Global Code of Practice on International Recruitment of Health Personnel, which committed the U.S. to more ethical practices around migration of health workers. And a key piece of that was that we should do a better job at meeting our own needs so that we don't have this vacuum bringing in and really drawing in very aggressively foreign educated health workers. So the question is if we meet our own needs or come close to meeting our own needs, then we wouldn't have to rely quite so heavily on migration. I'm going to go into detail just on 2 or 3 of these points. The first is around data, and I think this is really important. It's really exciting that there are actually a fair number of national data sources that the federal government has invested very heavily in that we can tap into for health workforce analysis. So the first, the American Community Survey, is an incredibly valuable survey, about 1% of the nation each year. It's the successor to the decennial census. It collects data on what people are doing and some, as well as their demographics. It allows us to look at how many practitioners there are by area, what their some to a certain extent what their education and training is, to a certain extent if they're foreign born, and other information about that profession. It also, interestingly, has information on race and ethnicity, so it is really a valuable tool to look at by geographic area the diversity of the health workforce. the National Ambulatory Medical Care Survey. I won't go into detail. And the next, the IPEDS, is the Integrated Post-Secondary Education Data Set that the Education Department produces. Has information, data on every graduate from a post-secondary education institution for the most part. Anyway, there are a variety, the point is there are a variety of data sources we can tap into. We did produce something we've called the Compendium of Federal Data Sources that's available on our website, which has information on what's available in terms of the data, but what's the geographic unit, how do you access it, what are the strengths and weaknesses. We've been promoting something we call a minimum data set, encouraging professions and states to collect consistent data on every health professional. We recently completed the new national sample survey of NPs. So I think there's a lot of work that's going on now to improve the data. A lot more has to be done. I'll just note the updating of the standard occupational classification. That's the core definition of what is a health occupation. And that's what the census uses, that's what the Bureau of Labor Statistics uses. It's really important because if we want to know more about nurse practitioners, it's really helpful that they added nurse practitioners as a formal occupation recognized by the SOC in 2010. So now all the data the US government collects will have information on nurse practitioners. They added community health workers in 2010. We need to refine that definition. We're going to update the SOC in 2018 and begin the process in about 2 months from now, asking for people to advise us if we should tweak or modify what we call, what are the health occupations, or what are the occupations of which healthcare is obviously important. So it's really an opportunity to help also identify emerging health occupations that we want to collect data on. The improved projections are really, I think, at the core of what we have to do, and it's the core of our challenges. We actually have a whole series of reports and projections in the pipeline, and we are reviewing the primary care projections report, which I hope will be out in the next several weeks. And then we have projections in all of these other areas using new microsimulation models. This is the core of what we do, yet it's one of the most challenging because while we can get some good data on some occupations in terms of the inflow, I mean, I can count medical students, I can count people going into residency training, where they're going and what they're practicing and how they're practicing and when they're going to retire. Our data is certainly far more limited. Anyway, we are working on a number of steps to try and improve the projections. And as I mentioned at the outset, one of the big challenges is trying to figure out what's the changing healthcare delivery system going to mean for how many practitioners we need. One of the best examples, I think, is the development of the patient-centered medical home. Now, many of you know the ACA has aggressively promoted, includes a number of provisions to aggressively promote the transformation in the delivery system. Patient-centered medical homes are one of the key strategies that are supported or encouraged. Well, which rely far more heavily on teams and assign responsibility to the home to manage care. You know, the reality is, though, I have no idea what that means for the number of primary care physicians we're going to need. There was an interesting study led by Al Schuler and with also Bodheimer and Grumbach in the Annals of Family Medicine last year. And they said if the family physician working alone, they looked at what a good practice would include in terms of acute care and prevention and chronic care management. They said you would need one physician for every 983 patients. And then they said if they have a heavy delegation working with non-physician clinicians, and that's NPs, PAs, but medical assistants and educators and others, then you would need one physician for 1,900 patients. Well, that range is enormous. You know, the first one says we need 315,000. The second says we need 159,000. One is we have a terrible shortage. One says we don't have a shortage. I'm not sure what to recommend or how to take this information and convert it into recommendations for the nation. I could put two scenarios and say, here's one scenario, here's the other scenario. You know, the problem with that is that doesn't really provide very much guidance. Should we be increasing a lot? Should we be increasing a little? Should we stay the same? So one of the key things we need to do is more research around how is the changing delivery system impacting on the health workforce. To do that effectively, you also need to consider the outcomes, because just counting what's going on may not be sufficient if the outcomes, in fact, are not equal. I will tell you that it was interesting. I was on a panel several weeks ago, or a few months ago, with some folks from some of the large group practices, integrated delivery system. They were talking about one primary care physician for 5,000 people. If we had one physician for 5,000 people, then I would say we don't have a shortage. I was even struck by that. Anyway, this is an area where more research is needed. We need to understand what is the configuration that delivery systems are using, and what's the impact on health, and then what are the ramifications for the health workforce. Let me just talk about some of the the changes in the healthcare delivery system. Most of this we know. Demand is rising. The U.S. population is growing and aging. That is the demographic reality. There's nothing we can do to change that. The U.S. will have a population in the range of 330 or 335 million in 2020. We are aging. Older Americans use far more services than younger Americans. ACA, the healthcare insurance coverage component, will add roughly 25 million additional Americans, give coverage to 25 million additional Americans. That sounds like a lot, but the reality is they already have some services, and 25 million people are only in 2020, only about 7% of the population. And so our studies and several studies in the literature project that the ACA is only going to add perhaps 2% to the demand for primary care in 2020 above what it would otherwise be. So the aging of the population, by our estimate, is probably 70 to 80% of the increase in demand has nothing to do with the ACA. So, but the reality is demand is increasing. At the same time, we're under great pressure to constrain costs. The uncertainty about our health workforce needs and whether we should be producing a lot more or not. But at the same time, there are concerns about inefficiencies and potential overuse. We hear that particularly from Dartmouth, but from others. And there is an increasing interest in finding ways to do things better. So we are seeing a lot of delivery system reform discussion, and some of this is being pushed very aggressively by the federal government through CMS and CMMI, the Center for Medicare and Medicaid Innovations, putting out literally billions of dollars for demonstrations and projects to redesign the delivery system. There's also a lot of what Clay Christensen would call disruptive innovations. And I think some of that, things like retail stores, when Walmart gets involved in delivering health care, but also the technology is going to be driving that. The expanded use of non-physician clinicians. I mean, a lot of things really disrupting the traditional way of delivering services. I also think there is greater attention to patient and consumer empowerment and the global responsibility. I mentioned the federal efforts. This is just a list of some of the activities and strategies that were, for the most part, included in the ACA to really spur on change in the delivery system. Now, one of the interesting things is in the first round of the challenge grants that CMMI awarded, close to $1 billion, those 107 projects had about 96, by my count, that had major health workforce components. And what we were seeing was a lot of people looking at, it wasn't just using NPs and PAs, it was really, can we use care coordinators? Can we use community health workers, patient care assistants, a whole range of workers who are trying to put together the pieces, the many diverse pieces, and really break down some of the silos in healthcare. But I think it really foretells where are we headed. We're really headed at looking at a whole new category or an expanded use of some of our previous categories of workers. One of the challenges for us is to try and figure out what are those workers. With 30 projects saying they're using community health workers, and you look closely, and there are really a dozen different categories of different types of people, different types of training, education, providing different types of patient. But again, to me, the bottom line is the healthcare delivery system is evolving. Tremendous challenge for us trying to do workforce projections. This is a slide that Buzz Cooper put together from work by Kendricks and Getson. And I think it's really important because when I looked at this recently, re-looked at it, it brought home the fact that while I thought that all these changes I was just telling you about the growth of the non-physician clinicians and the team being more important in the future, is really part of this long-term trend. I mean, the last 70 years, the role of the physician has been changing, and the role of other categories of health practitioners have been growing relatively rapidly over the decades. So what we're seeing is really a continuation of a very long-term trend. Again, I want to emphasize that the teams that we're talking about today, we should not be thinking about it as just the NP, PA, and physician, even though we spend a lot of time talking about that part of the clinical team. I think what we're seeing, and we're going to be encouraged by the accountable care organizations, are teams that are much more comprehensive. And this is also being supported by the growing size of physician practices and delivery systems and bundled payments, et cetera. There's a whole range. And if you think about the incredible amount of funds that are devoted to the chronically ill, that are very, some data came out recently that emphasized that how a very small portion of our population spend more than half of the resources, that it's a limited pool of people that have the greatest need, and many of their needs, or most of their needs probably, are not from the physician. It's really managing the chronically ill that's so important. And so all of these health workers are really important to an effective team. I do want to emphasize the growth of NPs and PAs because they have been growing so rapidly, and they are really important to the delivery system. So this is data from the American Association of Colleges of Nursing. And what we see is the number of nurse practitioners has grown phenomenally over the last several years, and are now at 14,000. The number of PAs has also grown rapidly, and I was reminded, I thought there were an additional 60 PA programs in the approval pipeline, and I was corrected. There are about 80 PA programs in the pipeline. Now there are about 180 PA programs. This is a major spurt, and this is really going to be an incredibly have an incredible impact. So when you combine the NPs and PAs, the 14,000 plus, the 6,000 plus, which means we're already over 20,000, and they're both growing rapidly, and we produce about 29,000 new physicians each year. So you see, going forward, NPs and PAs, the number of NPs and PAs are getting close, that we're producing each year, are getting close to the number of physicians we're producing. That's going to change how we deliver services. Obviously, one of the important questions is, how will physicians respond to the changing delivery system and the additional non-physician clinicians? How will the public respond? There was a very encouraging article in Health Affairs earlier this year, and I believe Michael Dill and others at the AAMC Workforce Center were the lead authors, where from a poll, they asked patients how they felt, consumers how they felt about the use of NPs and PAs. I will tell you, it was really very positive, and particularly positive for people who had had that experience. And so I think the concern about will the public accept NPs and PAs, I think, is not a serious concern, or it's a concern, but I don't see it as a serious problem. Most people will accept it, and I think that's what the data show. The question about how will physicians accept NPs and PAs remains to be seen. I will tell you, it's been interesting because some of the organized physician groups have been resistant. My sense is that the practicing physician, particularly the practicing physician of today, is happy to get support and help. It's interesting, there's some work coming out of UCSF, the Workforce Center there, about the use of medical assistants. And we're seeing that medical assistants are also playing an important role. So my vision is that physicians now, facing an increased demand, are happy to have assistants, a variety of clinical assistants to assist them. This is an area where I think, again, more research is going to be important to help us understand the extent to which it makes sense to use non-physician clinicians. So some closing observations. I think what we're seeing is, in general, the pressure to do more with less, but no one is saying we're going to spend less on healthcare. It's just we really are trying to constrain the rate of growth. I see a lot of pressure to use better use of the workers we have. I mentioned the teams, collaborative practice, the new categories of worker. There is a lot of work going on to reassess scope of practice. We have a cooperative agreement with the National Governors Association. They've issued a brief on NPs. They have briefs that compare scope of practice across each of the 50 states in DC. And they have briefs on PAs, pharmacists, dental hygiene, psychologists, and social workers that will be coming out over the next year. Again, we want to try and understand the difference in scope of practice across states. That will highlight differences. I think it's a great area for further research. And I think we'll find continued increase in the use of technology. I know there's been a lot of discussion about how much or how effectively we've implemented the electronic medical record. I have no doubt that we are in a transition period, and there are a number of bumps along the way, but clearly the improvements in health information technology and the electronic medical record are going to facilitate major changes in the future. I also think there really is an increased effort to align federal funds. That gets into a whole set of policy areas about how can we use those limited funds that we have to better promote change that's needed for the future. From the workforce planning side, I say, this is a really important time. The growing awareness, as I said at the outset, of the importance of having an adequate workforce. And I do see that as we move forward and implement the ACA over the next decade, that more and more people will say, yes, everyone or more people have insurance, but they still have access problems. Where and how are we distributing the workforce that we have? We are in a period of major reassessment about the health workforce, and again, I think there's a great opportunity, great time to do research in this area. We're developing the infrastructure for effective workforce planning. One of the things that's clear to me, this is time consuming and this is challenging. And I will tell you, I've been working in health workforce for probably 30 years, and if someone said to me, do we have enough neurologists or nurses, I will tell you this is a difficult question to answer. And we are doing more work. We have better data and we have better models. And again, I'm excited about these micro simulation models we've been developing, but they still leave a lot of questions. And forecasting the future is really, really challenging, but so important. Particularly important if you're talking about investments of tens or hundreds of millions of dollars in educational capacity. It's obviously important at the individual level to each individual who's trying to decide, does it make sense to become a dental hygienist? What is the future for occupational therapy? So this information is so critical, and yet I will tell you it is an incredible challenge to do it effectively. I think, again, we've made progress, and the ACA has really been a major step forward. Let me close by just throwing out some questions to ponder. And not that I expect answers today, but welcome your thoughts going forward. One of the questions is, should workforce planning be used as a very explicit tool? This comes out in things like, well, we think primary care is valuable. Should we say, we're just not going to pay for training of subspecialists? How much should the workforce be driving the delivery system versus workforce planning be responding to? And we've really taken the position more that we respond to. So if someone tells me where patient-centered medical homes are going, I'll try and translate that and say, well, if that's where you're going, this is what you would need, as opposed to saying we're going to force that change by how we produce or what we produce. Now, we are still debating how likely are we to face shortages. I do want to note that, as I said at the outset, the geographic unit is really critical because we may not have a shortage in some occupations nationally, but we may have serious shortages in local communities. This is going to come up in terms of nursing. because we put out a report last year, which with AACN data, which showed that the number of, the nation responded to the shortage of nurses that we had in the late 1990s and early 2000s, and we increased our production of nurses from around 65,000 a year to 150,000 a year. The question is, well, now we're at 150,000 a year. Is that enough for the nation? This question of shortages or surplus, it may be that it's enough for the nation, but it may be that they're not in the right places yet. So we really do need to do more to assess the shortages or surplus. An interesting question, do you think it's better to have too many or too few? I mean, if you have too many, the marketplace might like that because you don't have to pay as much and you can get them to underserved areas more easily. On the other hand, if you believe practitioners generate more demand, then you might say you'd rather err on the side of fewer. And the fact is, if you have fewer, you really do spur on efforts to improve efficiency and effectiveness. So again, an interesting question to ponder. I mentioned before the importance of trying to measure what's the impact of workforce changes and changes in mix on outcomes and cost. If we do have a limited physician supply, what's the best use of physicians? And the reality is, if you have a team there and we do have a limited supply, then we are looking at how do you reconfigure services. And the question of will they accept the role. I think we're going to have a continued debate about the future of the federal role. I will tell you that the ACA also authorized a health workforce commission. And there was incredible competition for the 15 slots and a lot of lobbying, and Dr. Mullen was one of the people selected for that commission 3 years ago. But as many of you know, that commission has never met. It was felt that they are a creature in the statute of the legislature, and the legislature, being Congress, needs to appropriate funds. And while the president has proposed funding for the commission, Congress, as you may know, has not been anxious to support any provision related to implementation of the ACA.
The House, let's be specific.
Oh, the House, yeah. I will be clear. The House. Some people in the House. And so the commission has never met. It remains to be seen if they will meet and what will happen in the future. They are on the books and they could play an important role. And then finally, questions to consider. As I've said before earlier, what's the impact of the changing delivery system? But with that, I would really, I'm searching for early indicators. And so, is there some way, can I identify a handful of patient-centered medical homes that I can monitor so that I know relatively quickly, like, what direction are they moving in? Are they, what is their staffing ratio? We sometimes sort of think we have to do big national studies to understand what's going on. But it may be possible that we can look at key indicators. One of the ones for the nursing workforce is, since 63% of the nurses still work in acute care hospitals, is what is it in hospitals I can look at each year to tell me what's the direction of nurse hiring and nurse employment in hospitals. So I'm really interested in saying what are the key metrics I can watch to know what's happening or likely to happen in the future. Anyway, that's the overview of the health workforce and where we are. And I look forward to any questions or comments that you may have.
So how have you factored in needs for behavioral and mental health services into this? Or have you not drilled to that kind of?
We're actually, the question about behavioral health workforce and how we're looking at the behavioral health workforce. We're working with SAMHSA, the federal agency responsible for behavioral health services. One of the initiatives that I mentioned was our minimum data set. And for the most part, we're trying to work with licensed bodies. So the Federation of State Medical Boards or the National Council of State Boards of Nursing, to get all of the state boards, when practitioners get a license and renew their license, to collect some basic workforce data, like where are you working, how many hours are you working, what are you doing, and what's the setting. We've included, with support from SAMHSA, we've been working with 5 or 6 behavioral health occupations. The challenge is some of those don't have a strong national infrastructure. You know, we're very specifically working with the Association of Psychology Boards. It's been a little more difficult to work with the social workers. We've been working with psychiatry and the substance abuse counselors and the licensed counselors. But again, the challenge there is there's not much infrastructure, and licensure requirements vary by state. And so it's not been as easy, not that it's been easy, but it's not been as easy as working with some of the other health professions. You can do some tracking using the IPEDS data on the number of graduates. So it's an important area, and it's an area that I think, you know, I appreciate your question, because I do think it's one that we need to pay attention to.
So you mentioned in what you were working on, you're collaborating with CMS, the CMMI Center, to evaluate the workforce components of some of the innovations and the new models. Can you talk more about that?
So CMS and the Center for Medicare and Medicaid Innovations has invested, you know, is investing billions of dollars to support redesign, and they'd asked for ideas for redesign. And as I mentioned, most of them have some health workforce component. CMS actually now has awarded 10 contracts for evaluation of the different groupings of those projects. One of them is in fact primary care change. I believe there are 14 projects involving primary care redesign. So we're working with them in the oversight of those contracts and trying to make sure that the contracts, when they go out to look at the impact on cost and quality, they also look at the impact on the health workforce. This is early stages. The contracts were only awarded about 2 months ago. And so we're trying to make sure we build in an adequate assessment of the workforce, to try and learn about what are the changes that are occurring.
I'm wondering how much a role retirement plays in the workforce supply, and whether that's a big factor, and also whether there are, if it is a big factor, whether there are interventions to keep people in the workforce longer.
Not surprising, it's a little easier for licensed health professionals to get data on the inflow coming in, because we can count graduates. The departures are really hard to assess. It also became more challenging because of the recession, and we think some of our data sources, we think that retirement patterns may have changed in the recession. They know that they have. We've been trying to use the American Community Survey, which has an interesting set of questions, which it asks you basically what you're doing today in terms of your occupation, but then it has a separate question, sort of what have you done in the last 5 years? And so particularly valuable for people who may be not currently working, so we can get some information. So we do think that there was a change in the recession, and retirement slowed slightly. We think particularly in nursing, which tends to be women, and men were laid off, and the spouses were more likely to stay working. We are worried that there could be a real surge in retirements as the economy improves, as portfolios improve. And while we have some estimates on retirement, this is one of the areas where we don't have good indicators to tell me quickly, like, okay, have they retired? It's actually more of a problem with licensed professionals, because a lot of licensed professionals will scale back, and even when they almost fully retire, will not give up their license. Physicians will say, well, I want to be able to prescribe, or, well, I want to maintain my nurse's license because I might go back to work. And so when, counting the number of people who give up their license doesn't tell you, the scale back in work. The American Community Survey can do it because they ask you the number of hours worked and your age. So you can go from year to year in the American Community Survey and say, nurses who are in their 60s, what are the average hours worked? Anyway, we're looking at it, and I think it's really one of the most important variables. I was at the AAMC, looked at physician retirement, and over the next few years, you're going to be reaching a point where about, say, 20,000 physicians are reaching retirement age. And if you think about it, if they retire 2 years earlier, to 2 years later, that's like 4 cohorts of 20,000, that's like 80,000. I mean, that's far more than the number we're producing. So those decisions do have an incredibly high impact on the overall supply. I haven't seen a whole lot about strategies other than hospitals over the years have talked about strategies of retention, but I haven't seen a whole lot about strategies to bring back practitioners. Although I think that the sort of natural evolution with the growing size of organizations delivering care, that it allows for greater flexibility. And so I have heard a lot of anecdotes of physicians who might have been in solo or small group practice saying, I'm tired of the administrative responsibilities, I want regular hours, and they can now move into organized delivery systems, and I think to a certain extent have flexibility on hours, so if they want to work 2 or 3 days a week. So it may be that the system is evolving in a manner that will facilitate flexible hours and therein flexible, keeping people in longer. Although we never know that if you have more flexible practices, whether that's going to encourage some people who were going to work 40 hours a week to now work 20, as well as bringing some people who were going to work 0 and are now going to work 20. So I don't know what the net impact will be, but it's an interesting area to look at. Are people retiring earlier or later? And I will note that the gender change in medicine, the gender change in medicine had impact because women and men do have different practice patterns, and women tend to take off more time around child rearing, definitely, than men. What we don't know is like women's retirement patterns, particularly the younger cohort that has come in over the last 2 decades, whether when they get to be 50, 60, whether they're going to work more than men or can retire earlier. Jean, I'm sorry.
Well, I was, you had mentioned all of the factors that you can't control that are going to impact workforce, and technology is obviously a big one, and particularly the home monitoring, sort of area, because it probably will cut down on numbers of hospitalizations and visits and those kinds of things. Is there any way that you're trying to kind of look at the home monitoring aspect of technology?
Well, I should note that that's reminded me. We just funded the 4 health work research centers. 2 of them, GW and University of North Carolina Sheps Center, are focused on something broadly called flexible use of workers and the evolving healthcare system, because we recognized how important it was to try and understand how this change is impacting on the workforce delivery. So I think GW will be looking a little bit at HIT, but that's actually such a broad area. One could probably have a research center was just looking at the impact of technology. And there was actually a piece, someone was holding a meeting, and I got a blurb marketing it about Geisinger and how their telehealth had a major impact on readmissions. Clearly, it has a tremendous potential.
Do you link the number of hospital beds in the country, the up and down of it, to sort of some standard staffing pattern, and make any projections?
We have not looked directly at that, but obviously important for nursing and other hospital-oriented professions.
Okay, I have a question. So when you look at like intermediary search organizations, or you look at like the Veterans Administration, where they kind of have a workforce that's not, like they'll have a home workforce of like family, friends, or they'll have like the people who are the disabled that are hiring these people directly. Is that included in that, or is there a plan to include that type of?
Well, the question about the Veterans Administration and how we look at that and whether they're part of our workforce planning efforts. We haven't isolated them out to do any specific studies. We have worked with our colleagues at the Veterans Administration some. The Veterans Administration is actually really, we should be paying more attention to for our general workforce planning, because they don't face some of the same constraints that the non-military, non-Veterans Administration delivery system face. They can use workers more flexibly, and they've really been in the forefront of developing teams. So I think we can learn a lot from them, and would welcome working more closely with them about how are they delivering health services. Fitz?
A different sort of question. You're probably the nation's leading expert and perhaps the leading consumer of workforce researchers, or people trained in workforce science or not trained in workforce science, but doing the work. And what are your reflections on that? And is there, we do have people clearly trained at the doctoral level who do focus on workforce research, but they've usually sort of stumbled into it or done it as part of an economics program or part of some other established scholarly discipline. What are your reflections? Should we be talking about doctoral level specific programs in workforce research, or is the current system adequate? How about the master's level? Should we have more focus there?
Well, not surprising. I think we need more. Yeah. So the question had to do with whether we should be promoting more masters and doctorates in health workforce planning with a health workforce focus. And I would agree with that we do need more. What we're seeing now is this really, as I mentioned, the increased interest. And it's not only about the work of the National Center. I get calls and emails periodically from professional associations of practitioners who say, we want to start a workforce center. We've been encouraging states to do more with workforce. And when you look around, there are very few people that have been formally trained. I mean, UNC Sheps has been one of the few areas that have been regularly, have a history of producing people. I think it's a great area, and it really needs people with economics background and sociology and psychology. So graduate programs that might take people that have various undergraduate backgrounds or concentrations would be, I think, make a valuable contribution. So this is a workforce planning. If I think the job market for health workforce planners is good, that more people will go into it. We do, as you know, we really do encourage it. And it's an area that, as I said, can be accessed from a whole range of different undergraduate disciplines. One more question, I think.
I have a question. It's interesting that you discussed retail clinics, and I wondered if you have any data on that. And they're kind of interesting in that they are so large and have the potential geographically to be to really be in very different places where healthcare is needed. So I'm wondering if there's any tracking of that and the information research on.
So the question is about retail clinics, and if we're tracking that. We haven't done, the National Center, haven't done any formal tracking. There are some associations that have data on, that represent the retail organizations. It's interesting, we've had a discussion with the National Center for Health Statistics that conducts the National Ambulatory Medical Care Survey and a National Hospital Ambulatory Care Survey. And the National Center for Health Statistics is trying to gather information on the delivery of ambulatory care services in the nation. And then the question came up is, are they missing a new and growing component of the delivery system? So last year we worked with them and they added a set of questions in the National Ambulatory Medical Care Survey to better get at the services provided in physician offices by NPs and PAs and other practitioners. Now they also, they now do physician offices. They draw a sample from the AMA master file. They do community health centers, and then they do hospitals. And then, but they weren't, the methodology was really about whether the physician in those practices saw patients. So we expanded it to say, when you go into the practices, you got to ask, did the NP or PA see the patient? It's interesting. They actually, if the patient was on a physician's panel and the NP saw the patient, they would record that visit as an NP visit. But if the NP or PA had their own patients, that wasn't recorded because they were just pulling it from the doctor's panel. So anyway, they're expanding that. And then they've come to us and said, well, are there NPs in particular that we're missing? And so an NP that would be out in a retail clinic would be missed if you're using the doctor's practice as your vehicle. So they're actually going to pilot test the sampling, doing a separate strata. of sampling of NPs and PAs. And they're trying to figure out again, or how much of the delivery system are they missing? And our NP sample survey also got some information on the NPs working separate from physicians. So we're coming at it from the practitioner side. It would probably be good if we had more information from the sort of organized delivery system side and that we kept track of that. I would note one other disruptive innovation coming from a different perspective, which would be concierge practice. And if and I don't know, I haven't seen enough lately, but if we're going to have some physicians who say, I'm only going to see 400 patients, well, that obviously is going to throw off those numbers in terms of how many we need. So we really need better information on how many physicians are in fact consciously limiting the size of their practice. And that may balance out those who are in large teams and serving more people.
But they're balancing out their practices because they're getting paid up front for the right to be called. So they're getting $2,000 or $4,000 a year for the right to be called.
No, yes, in terms of the right to be, they're doing it for a reason, and those patients are getting extensive physician access. But from the workforce planning perspective, it has such an amazing impact. Again, if we suddenly have some physicians who are only serving 300, 400, 500 people. Again, that example I gave, if they're only serving 500 people, we're going to need 3 times as many primary care physicians than we're programming. And again, this is a case where workforce planning following the delivery system as opposed to controlling the delivery system.
Won't that also only be on a coastal service? I mean, it'll go East Coast, West Coast, because that's where you have enough, because you're not going to be able to do that if you're in the Midwest.
Where the money
It
is.
isn't. It's where the money is.
Yeah. The question is, is this really a phenomenon only from the East and West, because that's where there's greater money? But again, I think this is the type of information we need to get. I have to think about whether our minimum data set we've been developing with the Federation of State Medical Boards is going to capture that. And we ask hours worked. We don't collect information on the number of patients or enrollees. Anyway, it's a tricky area. It's one where we probably need to find a way to get more information to find out if that's happening. So I know the time is limited, and I'm going to stop now. I'll be around for a little while if people have questions. So thank you very much.